Welcome everyone to today's webinar. Keys to Introducing Surgical Technologies and Building a Successful ASC Total Joint Program. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation and have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to welcome today's presenters. Dr. Michael Ast is an orthopedic surgeon and Chief Medical Innovation Officer at Hospital for Special Surgery. Dr. Michael Meneghini is an orthopedic surgeon at Indiana University Saxony Hospital. And Dr. Brody Wood is an orthopedic surgeon at Olympia Orthopedic Associates. With that, I'll turn the floor over to Dr. Meneghini.
Thanks, Alan. This is actually Mike Ast. I'm just going to take a few seconds to welcome everybody to our broadcast, I guess is what we're calling these nowadays, tonight. And thank you so much for joining us. I am joined by Dr. Meneghini from Indiana and Dr. Wood, who are really experts at this field. And you know, we're really at a very interesting time right now because we're sort of at the intersection of the transition to outpatient joint replacement, specifically moving over to ambulatory surgery centers, and the explosion of the use of technology in joint replacements. And so we sort of understand each of them individually. And, you know, Michael and I were joking earlier that we've been kind of involved in these conversations for about 5 or almost 10 years at this point. And it's no longer the, hey, are we going to think about moving to an ambulatory surgery center? These conversations are now, we are moving to our center. How are we going to do it well? And at the same time, many of us are in these conversations about technology in our joint replacement practices. What do we use, what works, what doesn't, and what works in each individual setting for each individual patient. And so tonight we're very lucky to be joined by a group of us who really have some great information that crosses that bridge. How do we safely and successfully do joint replacements in surgery centers? How do we understand and evaluate technology for surgery centers? And then when we have our surgery center up and running, how are we going to make that program successful, both from implementing technology and also from a patient satisfaction and outcome standpoint? So it's going to be a fun topic tonight. I'm really excited to be a part of it. I want to thank Becker's for hosting this for us tonight. And I do want to thank Ortholine for sponsoring it as well. But without further ado, I'd like to introduce a colleague and friend, Dr. Michael Meneghini from Indiana, to talk to us about outpatient total joint arthroplasty, safe patient selection. And in the world of outpatient joints, there's probably no one who understands and knows more about this than Michael. So Michael, thank you so much for joining us as always.
Thank you, Mike. Appreciate the introduction. And likewise, thanks to Becker's and Ortholine for putting on a symposium webinar on a very timely topic. So what I'm going to speak about for the next few minutes is really about the safe patient selection process that we've done a fair amount of work over the past 5 years in developing and perfecting. Certainly at this time of COVID, it's been instrumental. I did 16 surgeries this week, hip and knee replacements, including revision, and all of them went home the same day, which is sort of unparalleled. But I think our work to date has really positioned us to do that. So let me walk you through some of that. I think first of all, just as a note, my conflicts are relevant. I do get consulting and royalties from a company that's related to an outpatient risk stratification scoring methodology that I'll mention. And I also do have ambulatory surgery center shares, which is relevant to this topic. So if you look at outpatient total joint replacement, I don't think it's any surprise to anyone on this webinar that there's multiple factors fueling the rapid adoption. You know, initially, surgeon investment in surgery centers was something that was fueling it. Also, the ability for us to control our own operating room environment in a more controlled setting was attractive. And then, as we know, about 1.5 years ago, COVID came upon us, and we had significantly constrained hospital resources, which really put gas on the fire of shifting something that traditionally in my career has been an inpatient procedure into the outpatient world. And then finally, there's been some patient demand and the payer demand. So, episode of care cost control is something that's important to everyone, including the government. So it's not a shock that that's continued to accelerate, particularly in the post-COVID era. I would say we're still in the COVID era. If you look at why CMS made some of the decisions they did, if you look, this is 2014 data, but it was approximately a $7 billion annual spend. Not surprising that hip and knee replacement came under the microscope for cost reduction and shifting to the outpatient space because it costs roughly half as much in the outpatient setting. And so you saw the government signal this. CMS removed total knee replacement from the IPO list in January of 2018, and subsequently the last 2 years, total hips have come off, and then total hips and total knees now have independent codes for the ambulatory surgery center, meaning that both commercial payers and Medicare payers, Medicare patients can now have their hip and knee replacement in a freestanding ambulatory surgery center. And if you look at this study, this came from United Healthcare Group, which of course is the owner of a significant amount of patient lives, and they did a study looking at the impact of moving joint replacements into the ambulatory surgery centers. And if just 50% of those patients that they had under their care moved into the ambulatory surgery centers, it would save them $2 billion commercially and $1 billion in Medicare just from moving half of the patients. Now, I think they acknowledge in this report that patient selection is a key component. The impact we've seen in COVID cannot be underestimated, and here's some data to highlight that. And this doesn't even consider really our 2021 data, which I'm sure is even more dramatic. We looked at almost 1,400 primary hip and knee replacements performed at our hospital in the first 2 years prior to the COVID pandemic, and looked at the percentage of same-day discharge. And you see that the 2 years prior, we did about 20% of our total knees, and about 27% of our total hips were done as an outpatient procedure. Since we resumed electives about a year ago after the shutdown, a little more than a year ago now, 52% of our knees and 47% of our hips were done as outpatients. You can see that we also were doing older patients just based on the necessity, and also our selection criteria and the refinement of that has gotten better, and I'll walk you through some of that. Also, if you'd note, in 2020, we did double the amount of surgeries in our ASC. We're down about 20% in the hospital. Just shows you that COVID, as well as the original shifting that was occurring, has really been a site of care shift from inpatient to ambulatory surgery center. So if you look at that, this is graphically what you see here. You can see that dip in the COVID shutdown in April of 2020, and since that time, about double the amount was going to the ambulatory surgery center. So if you look at what I consider, I think many of us on the call would consider sort of the essential elements of outpatient total joint replacement, it really is this comprehensive list here. Got to have trained perioperative staff. Got to have a good partnership with your anesthesia. I think that's probably the most critical partnership. But to have a good multimodal pain control program. We certainly believe that having a perioperative medical program specialist is critical, and I'll walk you through some of that. Patient family education is paramount because the patients are going home the same day, so that educational piece has to be robust to provide that support at home. You got to have a good surgeon staff and nursing support in your own office, because instead of rounding on these patients, they're calling the office the next day as opposed to you seeing them in person. So you've got to be able to handle that. Optimized surgical techniques, I think, is important. You got to minimize soft tissue trauma, blood loss, et cetera, so you can get these patients out of the hospital the same day. And then finally, selecting the right patient. And that's been one of the challenges as we've now in the COVID era of seeing older, sicker patients with the necessity of either not having their hip or knee replacement or doing it as a same-day discharge. When you look at patient selection, it's multifactorial. You have to have a motivated patient. If they're apprehensive, that's a predictor of failure. They have to have good family and home support. They have to be in a good preoperative physical and mental condition. Uncontrolled depression is a harbinger for a poor outcome. We also screen for narcotic medications, and if they're on substantial preoperative narcotics, it's usually a red flag to not perform it on an outpatient basis. Minimal to moderate surgical complexity. You're not going to want, real massive surgical complexity done in an ambulatory surgery center. I will say we're doing simple revisions there now, and that may expand over the next 5 years. But for right now, I think it's better to play it safe. And then we look, and this is what we spent a lot of our time over the last 5 years, a lot of our effort looking at medical risk stratification to make sure we didn't have a poor outcome postoperatively. There is some literature on this topic. This is a study from 2017. Again, this is a sort of a meta-analysis of available studies. Not surprising, what they're saying is what's not appropriate for outpatient surgery, those patients with an ASA greater than 2 or obesity greater than 30. I will tell you, practicing in the Midwest, if I had to not do patients with BMI over 30, I probably would only have about a third of my practice. So that's not really applicable to us, but nonetheless, that's what those authors showed. Another study in the Journal of Arthroplasty 2017 was, of course, a NISQIP database. Understanding the limitations of database studies, they looked at a significant number of primary total joint replacement. And again, similar predictors of discharge, less than 24 hours, were low ASA, male gender, and then age under 50. Smoking and bleeding disorders and ASA 3 to 4 predicted adverse events. So that's pretty much common sense. And I would argue that that's what we've been doing up to date, is selecting those young, healthy patients. And that's relatively straightforward, but that's a relatively small percentage. If you're going to enact a true transformation to outpatient, which is what we're doing in this country and in the world, quite frankly, right now, that's really learning to address these older patients with more medical comorbidities. And so that's really pushed us to look further. And then how do you medically risk assess these patients? We traditionally have used ASA score. And if you've ever seen the original publication, this is it, 1978. Obviously, a number of things have changed in healthcare in 40 years, but nonetheless, this is what we still use, and you saw it quoted in those papers. And if you've never looked at it, I'll walk you through what it really involves. It is a survey of about 304 anesthesiologists, and only about 3/4 of those, interestingly, responded. They had 10 hypothetical patients, and they only agreed on a mean of about 6 of those patients, which is very interesting. And even the authors at the time said that the ASA score is useful, but it suffers from a lack of scientific precision. So we have believed for the past 5 years that if we're going to get to the next level in selecting patients properly, ASA is not robust enough. And I give my perioperative medical specialist, Dr. Pete Coccarvello, credit for that. He basically said, look, patients can have an ASA of 3, but be totally fine for an outpatient joint replacement. Here's a classic example that we routinely use to highlight this. Medical risk does not always correlate with ASA. So a patient, for example, with poor pain tolerance and a history of a postoperative ileus, or you could throw postoperative urinary retention in here, that would probably not be a patient to be done in your freestanding ambulatory surgery center, yet they are an ASA 1. Conversely, someone with stable coronary artery disease would be classified as ASA 3. We routinely do those patients in our ambulatory surgery center. Just did some this week. So someone gets a stent, they go through cardiac rehab, they're in great shape, they've got great exercise tolerance. That is an appropriate candidate to be done, same-day discharge in the ambulatory surgery center. And so I mentioned him earlier. Dr. Pete Coccarvello is really the mastermind behind what we've developed. It's called the ORA score. It's the Outpatient Arthroplasty Risk Assessment Score. It's medically risk-based, and I'll walk you through that. We published the original in 2014 and a follow-up to that, an updated 2017. We looked at over 2,000 consecutive hip and knee replacement patients. About 12% at the time, there was a large cohort, included patients before we were doing same-day discharge. And we looked at those patients to see their medical risk and see how they did. And here's really the take-home message. So on the x-axis of the graph you see on the right side of your screen, left to right is the length of stay, and then the y-axis is the score. Now, blue is ASA, red is the ORA score. And you want something with a relatively steep slope, meaning that it's discerning to go from same-day discharge to post-op day 1. And ASA is not horrible. If you see, it's 2.1 to 2.6, 2.6, et cetera, right there from 0 to post-op day 1 and 2. The problem is there is no 2.6 in ASA. It's 1, 2, or 3. So it's not very discerning, whereas ORA we felt was more helpful in that it has a greater slope, and you see same-day discharge patients had a mean score of only 18. If you look at the statistics and how it worked in that sample, it was exactly what we hoped that it was. It was an ideal confirmatory test. and it neared the ideal 100% positive predictive value and specificity. So what it says is you can't line a bunch of patients up, have Aura tell you who to do as an outpatient. What it does is it says if you as the surgeon and your team says this is a good outpatient candidate, we apply the score and it confirms it. It'll throw up a red flag if there's something that you missed medically and says, wait a minute, you should pause, maybe look a bit more in detail. Here's our 90-day readmission rates in that cohort to say, okay, if we're using this technology, is it working? And, you know, we were confirmed that it was. Our same-day discharge 90-day readmission rate in that cohort was only 0.4%. And as you would expect, as the longer length of stay, the sicker patients had slightly higher readmission rates. The nice thing about any sort of technology, if it's going to be valuable, is that it needs to be externally validated. And Rand Schwarzkopf and the group in NYU validated the Aura score. So we're happy to see. We have our own conflict and bias, but we're happy to see that that was done. And now we've got a large sample of national patients. That's now actually over 8,500 patients have been put through the Aura score to date, multi-center across the United States. It takes about 60 seconds to use the score, and you'll see that same-day discharge readmission rates are lower than next day and greater than 2 days. So we're ending up with lower readmission rates, same-day discharges, so it's working as designed across a largest segment of the population in the United States and multiple centers. One of the things I'll finish with and highlight is really how we do things and how we approach same-day discharge in light of that patient selection. And one of the things we feel very strongly about is patient selection is not a cure in a vacuum. Once you select the proper patient, you've got to have the patient optimized medically. We have a very close team of anesthesia. Our medical physicians and the surgeons all work together. We're big believers of IV resuscitation, multimodal pain protocols. And the reason I put the picture of an assembly line up there, whether or not you like Corvettes or not, the whole concept is that joint replacement patients, if you approach them in a very process-driven manner, it works very, very well. And the reason that's important in a freestanding ambulatory surgery center is you're delivering a product to the nurses in the postoperative recovery unit. And they may not be used to hip and knee replacement patients. They may be used to carpal tunnels or ENT or even ophthalmology or pain patients, you know, doing small injections. This is a different kind of patient for them. It can be challenging. So you've got to make sure your processes are dialed in so that a consistent product comes out for those nurses. If they've got a patient that you lost a lot of blood or you had an extended operative time and they come out into an ASC PACU unstable or with hemodynamic shifts or shifts in their pain control, that's going to really stress out the ambulatory surgery center. And so we really emphasize that consistent product that must arrive in the postoperative recovery unit. And I'll sort of finish on some of what we think is part and parcel of that is blood conservation. And we've worked a long time at really maximizing that for the ambulatory surgery center. So we do a number of things. We use tranexamic acid, both pre and post-op IV. We focus on surgical efficiency, and we use computer-assisted navigation on every knee replacement that we do. That we have shown, we published that if you use computer navigation, you don't drill into the femur, saves you about 1 gram of hemoglobin, in addition to tranexamic acid, which shows the exact same amount. Why is that important? We're not trying to stop transfusions. What we're trying to do is minimize blood loss or painful effusions in the knee. More importantly, minimize blood loss so you have a euvolemic state. You're not hypovolemic. So that's really important. We found that extremely valuable, and we use it in every case in our ambulatory surgery center for that reason, value added. And the final thing I'll mention is that we try and avoid the discharge failures, and as our work over the past 5 years have really highlighted these 5 things. So I screen for these personally for every patient as part of my patient selection process. I look, do they have a history of POR, which is postoperative urinary retention? Do they have uncontrolled sleep apnea? Are they on chronic opioids? Do they have a history of nausea or poor home support? If the answer to all of those is no, they're good, then we screen them with Aura. And with that process over the past 7 years since we've been doing that, we have had no patients fail to launch out of the ambulatory surgery center. I just had my first one, ironically, was just this past week. So I guess I have to change that to 1 one patient. But we have been very happy with that protocol in general. So in summary, I will just tell you that I think we know that this is accelerating. We believe that it's less costly and resource consuming. The pandemic has accelerated it. We believe patient selection is a critical aspect, and we still always emphasize putting patient safety first and foremost in the process. So thanks again for your attention, and I will turn it back over to Mike Ast from HSS to begin his portion of the presentation. Mike?
Thanks so much, Michael. That was great as always. I got to tell you, I think I've heard you give that talk, maybe 100 times now, and every time I feel like I learned something from it. It's just really great, and I love to see how you've matured over time in terms of just your general thought process on patients. And I think it hits back to what I was saying earlier, is this is no longer like a cherry picking only the very, very best cases, and it's going to be super easy because those patients are easy. We're really starting to look at now, how can we move large percentages of our patients over to the surgery center, and most importantly, how we can do it safely. So as I've said to you before, I'll say it again, thank you very much for the work you've done to help the rest of us in the orthopedic community do that safely and well for our patients. Moving on, I want to kind of turn to the second part of what I alluded to earlier, which is that it's not only that outpatient joints and ambulatory surgery centers are becoming more and more common, it's also that technology is becoming more common. And there's an old saying, it's sort of a known statement actually, that things like advanced technology have never entered a market and then left, right? So once we get good at using technology within a particular field, we continue to use that, continue to iterate it, and continue to find the best technology. So I want to talk a little bit today about bringing technology to joint replacements, specifically in the ambulatory surgery center. Because I think as we start to do more of our cases there, as we all start to get more comfortable with technology in our surgeries in general, we now have to start thinking about which technology we want to use in each case, and whether or not it's going to be the same technology between the hospital, maybe the outpatient department, and the ambulatory surgery center. So I've got some important conflicts. I do consulting work for some companies that run surgery centers. I also do consulting work for multiple companies that make technology that I'm going to allude to over the next 10 or 15 minutes. When you think about technology in a surgery center, you have to think about it in a couple of different ways. Number one, surgery centers have unique challenges specific to surgery centers, and any technology we evaluate needs to take those into account and understand them. We also need to see that whether or not the technology we're using addresses not only our clinical challenges, like the idea of making sure we're getting great patient outcomes every time, but also the other challenges associated with the surgery center. And then we want to make the right choice. And the right choice doesn't always mean making the same choice everywhere. Sometimes making the right choice means making the right choice for the right patient in the right place. So when we think about surgery centers, they really are different and unique institutions. And I've shown this picture before, and I bet you Michael just started laughing because he's seen it before. But this is my old surgery center, and I want you to notice a couple things. Number one, this is a wall-to-wall picture, right? There's nothing on either side of this, right? So this is a 327 square foot room where we did 600 joint replacements a year. Number two, you'll notice the lights on the ceiling say number one and number two, and they are not over the surgical field. That's because neither of them worked. And at the time, we simply didn't have enough cash flow to actually fix them. And so you do recognize that surgery centers go through very, very unusual and unique things when we start to transition, especially to higher acuity cases. It's the patient population that's a little bit different. It's the room size that's very different than a fancy hospital like some of us have. The sterilization capacity is very different, and cash flow can be very different. And all of these things need to be taken into account when you think about adopting technology and which technology you're going to bring to your surgery center. We'll start on the patient population because total joint patients in the ASC are a little healthier and a little less complicated than patients might be across the board. As you heard Michael say, you're probably not going to be bringing complicated revisions or very, very sick patients or very complicated surgeries where you're removing hardware or doing other things to your ambulatory surgery center. And so these patients are healthy, they're highly active, they're highly motivated, and they're usually just a little bit younger. The only problem with that is that younger, highly active, highly motivated patients actually have the highest risk of revision of all patients that undergo joint replacement surgery. And the only thing that's ever been shown to decrease that risk is the use of advanced technology like navigation and robotics. And so while we start to think that there are cost constraints associated with our surgery center, we need to remember that our job is to give these patients absolutely the best outcome we can. And that's not only because we care about each individual patient, but also because as we're growing our joint replacement program, every one of our happy patients and our successful patients is the best billboard, the best advertising we have to continue to grow that program over time. And so we know that technology improves our outcomes, which is why we should all be thinking about how we're going to adopt technology in our ambulatory surgery center programs. Like I mentioned before, room size is a really big deal, and it's a bigger deal in a surgery center than it is in a hospital. If you look on the left side of this screen, that's what a traditional total knee replacement setup looks like at the hospital, right? 6, 7, 8, 9 trays sometimes, too many instruments, too many things. Traditional ASCs don't have rooms for 3 back tables or for double-decker back tables or to sterilize all of this stuff. If you look over here on the right, this is a picture of our back table at our surgery center, right? It's 3 trays plus our basic instruments. It's a single table and a single Mayo stand. And the way we can do this is because the technology that we utilize allows us to minimize trays, minimize the need for sterilization, and be able to do things with a much smaller footprint. And I know I alluded to it earlier, but sterilization is one of the major limiting factors for growth of most ambulatory surgery center programs. You'll see on the right, on the left side of the screen, that's a picture of a standard hospital-based sterilizer. You can sterilize somewhere between 8 and 12 trays at a time. Really easy. If you're going to do a case that has 8 or 9 trays, no big deal. It's 1 sterilizer cycle. You'll notice the Easy Bake Oven on the right side of the screen. That's actually a sterilizer made for an ambulatory surgery center. Remembering, of course, that when many of these centers were started, they were just for hand surgery, ENT, GI, a little bit of sports medicine. They never expected to take 9 trays and sterilize it for 1 case. 9 trays should have been their entire day or potentially even their entire week. And so you need to take this into account when understanding which technology is going to work for you, because you need to address this problem as well. And finally, cash flow, because if we're going to have a conversation about ambulatory surgery centers and not talk about the economics, we're really just not having an honest conversation, right? ASCs have less working capital, potentially lower volume than a hospital might have that you could use to offset costs. Like, let's say you're going to take a discount on your implants and use that to offset the cost of some technology. The problem is you're not going to do 5,000 cases a year at your ambulatory surgery center, right? Most surgery centers are going to do 50, 70, 100. Maybe the busy ones will do 150, and so it's not so easy to offset some of those costs. Also, the owners expect distributions, right? The joint replacement surgeon isn't the only person in the room, and it's very difficult to convince the ENT doctor or the GI doctor that they need to give up money out of their pocket so that the joint replacement surgeon can come and take their share too. And there's also other significant early expenses when building a program, and I know Dr. Wood is going to go into some of this later about building your program and building an efficient program, but you've got to keep in mind that when you're buying power tools and bigger mallets and beds for people staying in the PACU longer, all these things cost money, and so what you do with upfront capital expenses really matters. So the question is, can technology answer these challenges? Is there some way that we can use the right technology to do that? And I think they can, as long as they address reproducibility, limit the need for sterilization, improve our outcomes, and ultimately it'd be nice if we gather data as well. And there's a lot of options out there, right? There's a million options. We can look at these crazy screens of these robots and these pseudo-robots and these smart technologies and all of these things, but ultimately we need to get through some of the noise and understand what each of them does. And even our hosts here tonight are talking about it, right? This is an article from earlier this week out of Becker's saying, are surgical robots important to ASC growth? And the answer is, I don't know, maybe, maybe not. I do think surgical technology is important to an ASC program. Whether or not growth is the only reason you use it might just be what you're looking for at that moment. I think growth is one of the things you can use technology to do, but there are some other things you should also be evaluating to make sure that the technology you choose is the right one for you. So I look at it as the correct technology for the correct patient in the correct setting. And when you evaluate the types of technology, I break them down into sort of the smart technology, the smart instrumentation, which usually fits within your sterile field, oftentimes does not involve a huge amount of large footprint, and has some other unique things to it, but often doesn't involve a motorized portion that actually does any part of the surgery. When you think about robotics, robotics is actually defined as an end effector that does something. So not even all of these robots are actual robots, but these larger systems are console-based navigation with enhancements. And I think those enhancements are very valuable, and in many cases they're really great. And I do use robotics in my practice, so I'm not trying to say anything bad about it. I just think it's one of the things you need to consider is exactly what you're getting from each technology and how it fits into your practice given your particular site of service. And then we can't say that those are the only two, right? Let's talk about some of the fun and interesting ones coming down the road. What about augmented reality, the idea of technology that superimposes a computer-generated image on a user view of the real world? And I'd be remiss if I didn't take a chance and plug HSS and show that this is Dr. Jonathan Vigdorchik, not only my partner, but he was also my co-fellow, and he's one of my closest friends. We actually taught our kids to ski together. But he did the first augmented reality total knee replacement in America right here at HSS earlier this year. And so maybe this is the future, and maybe these are the types of technologies we'll eventually be looking at. So I think it's important that we always keep our mind open and our eyes open and understand what's really out there. But when we go back to that correct technology for the correct patient, the correct setting, we have to think, well, first of all, who are these patients, right? These are the healthy, highly active, highly motivated, minimally complicated joint replacement patients like we talked about earlier. So do you need the absolute highest level of technology for these cases? Maybe you do, maybe you don't. This is a decision you can make. But remember, these shouldn't be your super complicated, fused spine, proximal femur deformity hip replacement patients, right? These are probably going to be your more straightforward cases, and you can evaluate what technology is appropriate for each of those cases to make sure you achieve the goals that I alluded to earlier, which are good clinical outcomes and the ability to be predictable in what you do. And so every program is going to be different. Some larger programs have higher volume. Maybe they have more cash flow. Maybe they have more access to capital. Most surgery centers in the country are actually quite small. In Maryland, there's 250 surgery centers. They all have just one room. And so these might not have that type of volume. They would be lower volume. They might have potentially limited cash flow or limited capital access. And again, back to that limited sterilization capacity as well. And so if you look at robotics, you've got the pros of accuracy and definitely some marketing, and also the fact that some surgeons are very comfortable with it. They have access to it at the hospital, and they'd like to do the same thing at the hospital and the surgery center, which is something I absolutely advocate for. I think you should not change anything about what you do when you move from the hospital to the surgery center. You need to be comfortable at the surgery center as a new place, and only when you're really, really good at surgery center joints can you think about deviating from what you do in your standard. And some of the robotics programs are full platform with hips, knees, and unis all on there. The cons is they generally have a large footprint. They're not always super mobile from room to room or even surgery center to surgery center. Many of them are limited to a single vendor, which may be good and may be bad. It's just this position that you're in the unique situation of your program. There's often maintenance costs and disposables, and even in some of them upgrades. And these vary between the systems, and it's just important to understand these, look at these, and evaluate them within your particular program. When we look at some of the smart instrumentation, it's got some pros of accuracy, right? It's got 10 years of clinical data showing its accuracy. Most of these are open platform programs, so you can use it for any manufacturer, any implant, which is nice when you're implementing multiple implants across multiple surgeons, but you're trying to create a single technology to use because you're using that technology to advance not only your outcomes, but also your work stream, in which case having the same technology is very nice. These are full platform, single tray. So in one tray, you can do a hip, a knee, a uni. And again, you saw this tray earlier. It's a pretty small tray. It's pretty easy to use. There's no footprint in the room at all. There's no upfront capital cost. There's no upgrades. And there are no mobility concerns. And so in some ways, this is a very optimal type of technology that you can use to get the outcomes you want. If you're trying to avoid some of the downsides of some of the other technology options. It's certainly not the only option, and I don't think it's going to be in every single surgery center or perfect for every single person, but in many of our programs, I think it's the type of technology that can really get people the answers they need across their entire gamut. And there aren't really a lot of cons to these types of things, except it is a single-use disposable cost, and so you do have to factor that in when you're thinking about your facility fees and your distributions and whether or not you want to implement some type of technology at all. So in conclusion, I think technology is increasing in joint replacement across the board, and it's not just at the ASC. The ASC is just one place that we do a lot of joint replacements now. ASC patients are the highest demand and benefit the most from the advantages of advanced technology. And also ASCs have their own unique circumstances that need to be addressed by the technology that we choose. And each ASC program really needs to take a look and decide on their own what technology is going to be best for their patients and their program. And I think the great thing is nowadays, 2021, going into 2022, there's a lot of options out there. There's really great solutions, and I encourage everybody to take a look at all of them and see what works best in your system. Thank you very much. And so with that, I'm going to turn it over to Brody Wood from Olympia, Washington, who's going to talk to us about building an efficient ambulatory surgery center total joint program.
Yeah, appreciate the introduction. Want to thank everybody for joining us today. I'm coming at this in a different fashion, probably more related to, clinical experience as opposed to, academic center. My background is I trained at the, University of Pennsylvania Medical School, and then went back to my hometown of Seattle and did my orthopedic residency there, and have been down in Olympia, Washington, an hour south of Seattle the last 28 years. My first love in orthopedics was actually trauma. I lost my brother in a traumatic accident, and that was my first love, and gradually transitioned into a general practice. And then over the last 15 to 20 years, I think driven by my enjoyment of what Tom Brokaw calls the greatest generation. I like the older population, and that kind of drew me into total joints. So pre-COVID, I was doing roughly 1,500 total joints annually, and that became kind of the primary aspect of my practice and what I enjoy doing. We're going to move to, hang on just a sec, I'm having a little screen issue here. These are some of my disclaimers here. If you can advance the slide for me, that'd be great. Thank you. So our group began in 1971, single-man group that gradually grew to a 5-man group, and then we coalesced with 3 other groups in town to form one multi-specialty musculoskeletal system. I currently have 22 physicians housed in 2 major offices, one with the surgery center, and we have seen, as has been mentioned before, that the ASC growth has been markedly accelerated due to COVID. We have seen hospital shutdowns. We were shut down for 3.5 months last year. And this year we've been shut down another month, and that's to extend into November, we're told. So we are, as orthopedists, being relegated to a non-essential status within the hospital. And that has prompted the desire to not only enjoy our surgery center as much as possible, but to build a second center with overnight stay capacity. And so huge tailwind from COVID, as mentioned previously. Can you advance? Thank you. The ASC journey has been interesting, and we've heard about the kind of change in patient distribution, but there has been an immense change in where care is delivered. We're witnessing probably a 10-year change in the last 18 months owing to COVID. We've seen e-commerce grow, and we're seeing surgery centers grow. And we at our center currently perform 1,000 primary total joints annually. And as was mentioned, I think, by Dr. Meneghini, we also are doing some simple, one-stage revisions as well. But we expect that number to rise to in excess of 2,000 joints annually in the next 3 years. Now, the hospitals are not unaware of this, and the Hospital Association is pushing for a clawback from CMS for total hip arthroplasties to pull them back into the hospital center, because they do realize that they are losing the lion's share of their revenue from the OR with us departing. If you can advance that slide. Now, within the ASC, there are huge clinical benefits of computer-assisted surgery. We've seen a marked reduction in abnormal implant position. Anything that exceeds 2% of varus or valgus is considered in that category. As mentioned earlier, reduction in blood loss of 25% and lower revision rates in young patients. And I see the top 2 categories as benefiting my practice the most. I have a practice where patients expect perfection, with their incision, with the alignment, and really want a kind of a worry-free recovery. And I can tell you that alignment of a leg or position of an implant, as you move into the ASC and own the patient experience, you really want that to be perfect. And we've seen that kind of improvement with computer-assisted navigation. In the NOM study mentioned there at the bottom of the page, they showed that a high-volume surgeon could improve perfect alignment from what was typically 70% up to 97%. So nearly a 30% increase in perfect alignment x-rays with the OrthoLine tool. And I've experienced this in my own practice. Since using it, the x-rays postoperatively have been perfect. We have not seen problems with varus, valgus improprieties. Go ahead and advance. Thank you. So it's certainly the impression with computer-assisted surgeries that these consume time, space, and money. But this is not always true. In our ASC, we shoulder all costs. And the inclusion of OrthoLine for improved outcomes has proven in our center to be cost-effective and profitable, and currently is growing in usage among the surgeons. The time and space that they occupy are negligible, and it fits in very well with the kind of the smaller footprint of the OR. Go ahead and advance. With the OrthoLine navigation, well, I came to it organically. I had a high-volume practice with enormous efficiencies. I had been with the Stryker Triathlon cemented knee for about 5 or 6 years, but I wanted to move to an uncemented total knee for both the efficiencies within the OR, but also the promise of greater longevity. In the first 300 cases, I had 6 female patients that had collapse of their tibial implant in an anterolateral way. The anterior lateral tibia collapsed down, requiring revision. And I attributed this to trabecular disruption from intramedullary guidance. And that caused me to then move to an extramedullary guide, which I honestly hadn't used since residency. And it worked very well most of the time. But what I found, particularly in the morbidly obese, that occasionally we would get a knee in a slight excessive valgus, and that was very disturbing to me. And as a result, I started researching different robotic means and came upon the OrthoLine. And I love the OrthoLine as an alternative to the larger robots that occupied the OR, had significant registration time, and it just made the OR more complicated. I found the OrthoLine elegant, understated, and I found that my PAs and I, within 1 week, were able to diminish the time to the tibial cut with, from 3 minutes down to 20 seconds. So the time it took was not a barrier any longer. I typically am doing 9 to 10 total joints within the surgery center from 7 a.m. to 3 p.m. And we saw no reduction in the speed at which we could perform these surgeries. It also allowed me to really, in a very finite way, to dial in the amount of slope that I wanted. It's a highly accurate tool. I usually prefer a 3 to 4 degree posterior slope on my cut and a 1/2 to 1 degree varus cut. And that varus cut is for 2 purposes. 1, to offload the anterolateral tibia where the bone is weakest, but also 2, patients prefer a slightly varus, neutral to varus knee. Cosmetically, they see it as athletic and an improved look over a valgus knee. The OrthoLine is agnostic. It works with all companies. There are no capital costs or service agreements, just a per case use fee, which we did not find to be detrimental to our bottom line financially. I I will say that the use of Ortholine is stepwise, involving two major elements, one of which is the mechanics of the computer. The number two is the judgment of the landmarks of the leg, the depth of the cut, the slope and angle of the cut. And this creates a dance between the surgeon and assistant. The assistant being responsible for the mechanics of the computer, and me, looking for the landmarks and whatnot. And when this dance is polished, you've got a 20 to 30 second time frame that you're requiring for each cut. So really a huge advantage in that respect. Change the slide, please. With regard to the surgery center, and this has been mentioned previously, I think Dr. Ass talked quite well, but you need excellent pre-op patient preparation. Prior to arrival, we need prehab, cardiac clearance, diabetic management, A1Cs under 8, O2 optimization. We need to make certain that people are not pain medicine addicted, and a strong family support plan. It's absolutely essential that the surgery center start on time, runs on time. Turnovers are quick, allowing me to be the rate-limiting step. We've also created specialty teams. I work with the same OR nurses, the same techs, the surgical scrub techs, every day I'm there. And this creates, again, a dance where surgery is efficient. It takes on the look of an Indy 500 pit crew. The anesthesiologists have to be quick with not only induction, but adductor canal blocks. And we need great control of postoperative pain and nausea, and that's accomplished through blocks, local injections, and also scopolamine patches have been quite helpful. Patients are typically visited within 90 minutes of arrival to recovery and typically discharged within 3 hours. The glue that holds all this together, though, is our nurse navigator, who becomes the liaison for the patient both pre- and post-operatively, and really an essential, vital person in this process. Additionally, I have to tell you, I give my cell phone number to every one of my patients. So when they leave the surgery center, they have my number, and I encourage them to call for any questions, any worries. You'd think you'd be beset with thousands of calls, but it's surprising how few I get. And that's turned out to be a very good tool in giving patients, a comfortable experience and access to the surgeon rather than a triage center or whatnot. Advance the slide, please. I would say that in my practice, I prefer bounce rooms. I don't know how many of you out there use them, but that creates maximum efficiency. It allows me, as I mentioned earlier, to be the rate-limiting step. Not everybody's maybe comfortable with rooms waiting on them, but if you are, I think a bounce room has made our surgery center an incredibly efficient place. It also mandates that you have reproducibility in what you do. Surgical times of under 30 minutes are preferred, certainly no more than 45 minutes. And the ability to make yourself, I don't want to make this impersonal, but a printing press, to make yourself reliable on a case-by-case basis, I think is imperative. And this requires some personal insight for every surgeon to ask themselves, are they the person that feels comfortable with this? It doesn't happen overnight, and some never achieve it. But to have an effective surgery center that produces an end product that is reliable and, as mentioned earlier, is comfortable for the nurses to care for with minimal blood loss and avoiding hypotension and avoiding all the things that can come with messy surgery, really makes things run well. You could advance that slide. I'd say with the Ortholine, it offers accurate alignment, reproducible alignment. I've not had one case since its use with postoperative abnormality. It eliminates all outliers for poor alignment. After 50,000 surgeries, I don't need a robot guiding my hand, but what I do need is excellent alignment. I found that that's one thing I cannot give myself, and that's why I turned to this and why it has been so beneficial to me. In summary, in closing, I would tell you all that the shift from hospital to ASC is rapidly approaching. Most care will be delivered by ASCs going forward. And we need to offer patients value and excellence. We need tools that offer value and improve the end product. We need tools that are small, not space occupying, that are efficient and not detrimental to our financial bottom line. And in my practice, Ortholine has offered that. It's a highly accurate tool. It's a fun tool to use. It's something that I do use in 100% of my cases now. And I welcome any questions as we wrap up this afternoon. And off to Alan now.
Okay. If our other moderator is not going to jump in, I will happily do so. I want to thank our speakers for incredible talks. That was really great. We do have some questions. We do have some questions over here that came in from the audience, so I'm going to just sort of shoot them. I'm sorry?
Apologies for that. I think I'm coming through okay on my end. Can you hear me okay?
All right. Now we can, yeah.
Thank you. Got it. So thank you so much to all our presenters for that great presentation. We'll jump straight into today's Q&A session. We've got a ton of questions coming through, and we'll try and get through as many as we have time for. First question related to technology. Do technology specifically related to robots and navigation increase the cost of care?
So there's sort of a short answer and a long answer to that. It depends on the episode of care you're discussing. Using some type of technology probably makes today slightly more expensive. It makes the overall cost of care lower because we do know that using technology reduces revision rates, and revisions are what drive cost in most of what we do. So some of it depends on the time frame at which you're looking to answer that question.
Yeah, and I think this is Michael to add on to that. I mean, I think the type of technology and the cost of technology, and to Mike's point, how that technology is purchased and where that cost is allocated are big factors into that. So if it's a capital expense versus a per case cost, for example, if in your ambulatory surgery center you're doing commercial payers versus you're trying to do Medicare payers, you know, those rates are different, your margins are different. And so you really have to evaluate technology for the value that it provides. I think that surgery centers aren't like hospitals where they have huge capital budgets. And so that's different. I think that's where something like a handheld navigation from Ortholine can play a value because, you know, these ASCs don't have large capital expenses to buy $1 million robot. And so it can provide some advantages there. And so I really think that's the technology is evaluated on a facility by facility basis. But I do think technology, I think all the speakers would agree, technology plays a role in optimizing patient care. And so we have to make that fit in the care continuum somewhere along the pathway, particularly in the surgical technique.
Got it. That makes sense. Thanks for walking us through that. Next audience member asks, is there a labor shortage for staffing ASCs due to the COVID impact on hospital systems?
I can touch on that. At Olympia Surgery Center, we lost a significant number of nurses early on that as daycares were shutting down, they found no one to care for their children and had to depart. And then just recently, our Governor Inslee has mandated that all workers within healthcare be vaccinated. and we had a certain population of our group, 40%, that were unvaccinated. And when this mandate came down, roughly 50-50, about 50% of those went ahead and got vaccinated or sought out exemptions, and the other 50% just quit. So we've been severely impacted and continue to be by this pandemic.
Got it. That makes sense. Thank you. Next question in regard to their patient population, specifically around the Medicare age. Do we have a population that is primarily Medicare and age of 65 and above? How do we meet the need of the outpatient surgery in this population without risking complications?
Yeah, I'll take this. This is Michael Meneghini. I think what we've noticed is that if you apply the sort of selection criteria that we outlined in our talk, you can do plenty of Medicare patients. It all has to do with really evaluating their medical comorbidities and whether or not they're controlled. For example, diabetes, plain old diabetes. If it's out of control, you shouldn't do surgery anyway. That patient's not appropriate for the ambulatory surgery center. But if it's well controlled, they can go to an ambulatory surgery center and have or have it done in the hospital and be discharged the same day. So it's not really binary. It doesn't mean that if you're Medicare, you can't have outpatient surgery. You probably have to be a bit more discerning from a medical risk perspective. But there are plenty of Medicare patients that are appropriate for same-day discharge, and I think we're seeing more and more of that on a daily basis now, especially in the COVID world. I don't know, Mike and Brody, if you feel the same way, but we've certainly been doing a lot more Medicare patients as same-day discharges.
Yeah, Brody Wood here. I would say that, we've been at this 10 years now with the ASC experience. And when we first started out, our criterion for patients were extremely stringent. We wouldn't do anybody with a BMI over 30. We wouldn't do anybody that required home O2. Anybody that had sleep apnea was not allowed. And over time, as we have learned, we've been able to relax these restrictions. We take care of patients now with sleep apnea. We will do BMIs up to 40. We will, but agree, that people have to be optimized. The A1Cs have to be under 8, and all pre-cardiac clearance and all that is taking place. But like anything, as you spend more time with it, you become better at it and can loosen those restrictions.
And this is the second question I've seen sort of in the list talking about the safety of surgery. And keep in mind the data is pretty strong to suggest that outpatient surgery in properly optimized patients is at least as safe, if not safer, than inpatient surgery. So the idea that doing a surgery as an outpatient makes it more dangerous or is going to give you a higher readmission rate has not been borne out in the literature. Unfortunately, we are running out of time here. I do want to thank everybody, and certainly if there are any other questions, I know and I'm sure the rest of the speakers would be happy to answer them. If you want to shoot us an email or get in touch with us somehow, we'd be happy to answer all of them, but we do want to respect everyone's time. I know Brody said it's getting into the afternoon where he lives, but for me, it's 8 o'clock at night. So we want to thank everybody for tuning in this evening. I want to once again thank Becker's and thank Orthline for sponsoring this. I want to thank my two co-speakers here tonight who did an absolutely fantastic job. And just remind everybody out there that I think this is the kind of conversation we all need to be a part of. We need to actively look to make sure that the programs we're involved in are doing the best things for our patients, the best things for our surgeons, and the best things for our healthcare system in general. And I think that happens somewhere in the intersection of appropriate patients in the appropriate site of service, getting the appropriate surgery, and the utilization of appropriate technology for each of those situations to make sure the patients get the best outcome possible. With that, thank you very much to our panelists. Thank you to everyone who tuned in this evening, and I wish everyone a great afternoon, late evening, or late evening.